We're going to have another fun conversation here because in the last, you guys weren't all on the same panel, but each one of you said such interesting things on your different panels. We were like, we got to get these two guys together and let's just see what kind of sparks we can make fly. So that's great. So the topic, of course, is about hybrid care as we've been discussing. And what we really want to talk about is who is telehealth really working for? And, what are the successes and the mismatches going on in the rollout? Just in our last session, we posed a question. We were talking about health disparities and equity, et cetera. And we posed a question about, where do we think the inequities lie and how do we actually start with the hardest patient populations and then make it trickle up to everyone else, as opposed to the inverse, which is, let's deal with the wealthy and the folks who can afford it and let them trickle down. A lot of what telehealth we've seen over last year through, as Nabil said in our last session, was a burning platform. Therefore, everybody was doing it because of the fact that it was a burning platform. There was a lot of course, reimbursement changes that occurred. But as things start to settle into some new normal, as we're going to go forward, thinking about why things were successful and where they weren't is probably worth doing at this time, because a lot of us have to make budget decisions about what to do in the future. So that's what we're going to talk about here. I'd love for David, you to introduce yourself first, then we'll go to Rasu, then to Judd, and then I'll pose the first question. So David, introduce yourself and what you're busy with these days.
Sure, great. So I'm David Fletcher, Associate VP for Telehealth at Geisinger, a fully integrated health system in largely in the central Pennsylvania area. We have about 9 hospitals. And so I've been in this role for about 3 years. And then before that, I was at the University of Arkansas for Medical Sciences and telemedicine for about 13 years. So over 15 years in telemedicine, which in this industry, sometimes I find I'm like the grizzled old veteran because it's such a new industry. But so yeah, we've had a huge uptick in telemedicine during COVID, and I think exactly as you said, we're kind of starting to take a deep breath and like, okay, what have we done, and how do we make good decisions going forward to build off of some of the great momentum we've had.
Awesome. Rasu?
Hi, everyone. Rasu Shrestha. I'm a radiologist by background, and I'm the Chief Strategy and Transformation Officer here at Atrium Health. We're across the Southeast, headquartered out of Charlotte, North Carolina. As a radiologist, teleradiology and telemedicine is something that we've been adopting now for a long, long time. And I talk about virtual care, telemedicine as an overnight success story that was 30 years in the making. Right? So with the pandemic, you saw how everyone was like, oh my goodness, and the funding, all of the companies, the innovations and all of that. But it was 30 years in the making. So there are lots of opportunities in terms of how do we really capitalize in on that momentum that we saw in the last year and a half, building off of the 30-year runway that we had, but really make it sticky moving on forward. So really looking forward to this conversation.
Awesome. Welcome, Rasu. Judd?
Yeah, I'm Judd Hollander. I am the Senior VP for Healthcare Delivery Innovation that telemedicine rolls up to at Thomas Jefferson University. And I also have an Associate Dean role. So as we've grown out telemedicine over the last 6 or 7 years there, we've actually coupled that with a big academic presence, have over $10 million in federal grants, NIH type grants and whatnot, and robust programs. So we're launching a master's program in healthcare delivery innovation science, where you could actually major in telemedicine, as well as a host of other programs.
Love it. Anything where we're going to move into more structured education around this couldn't come at a better time. So maybe I want to start with one more difficult question first, because you guys have been doing this for a while, so we'll ask a more difficult one. We know before the pandemic, there was a lot of guesswork as to, lots of people might be interested in telehealth and telemedicine. Then during the pandemic, we had the burning platform. It was required in most cases. So we went from pure assumptions to maybe some skewed numbers from last year, maybe going into this year, from 2 reasons. One is acceptance by patients because they had no choice, and the fact that you had reimbursements that are not going to look the same way over the next couple of years. So just from an analytics perspective, what are you guys seeing where we can trust the numbers about consumer preferences enough to make budgeting and predictive decisions going forward. Rasu, we'll let you start because you've got the biggest system to deal with, so you have maybe a little bit more data. And then I'd love for David and Judd to come in and poke holes in that as well. So what are the analytics teaching us about what data we can and will be able to trust?
Well, thanks for asking that question. And as I mentioned earlier, I'm charged with strategy and transformation across Atrium, and we have what we call the strategy and transformation office. As part of that, there's the strategy planning element, that's the innovation component. But there's also what we call new ventures, as we look at initiatives such as telehealth and specific ventures around that, marketing communications, but last but not least, data and analytics, which goes back full circle to your question around what does the data say? What is analytics teaching us about consumer preferences? So we take a very data-based approach in our strategies and the specifics of the care transformation elements that we're seeing across the board. At Atrium Health, our data reflects that less than 10% of patients prefer to only see their primary care provider in person. Now think about that for a while. Just less than 10% say that they only want to see their primary care provider in person, meaning the rest are really open to more of this hybrid approach, really open to other elements of telehealth and virtual care that we can actually put in place so that their experience is truly bettered, right? So when you look at that from a consumer preference perspective, our goal here is really to engage them within their what we're calling their rhythm of life, not just on an encounter basis, right? Because it's been very episodic. Healthcare has been very episodic, and our entire approach to virtual care, even through the pandemic, has been on and off, binary, right? Is it an on switch or an off switch? Is it virtual or is it in person? And the way that we're looking at this, especially based on the data that we're seeing around consumer preferences, is that it really has to be much more pervasive. It has to be built into the fabric of care transformation and care delivery, where virtual becomes an enabler of better care and leverage when relevant, even for care paradigms that are traditionally very much in person. I know we'll talk a little bit more about that, but for example, surgery. If you're getting surgery, I'm not saying we're ready right now to do virtual procedures, even with you sitting at home. We're not. We're absolutely not. And it's going to take us a while, even if that is something that we want to aspire to. But prehab, that's absolutely something we can take care of from a virtual perspective. Post-hab, really things that that we can really accelerate the elements of what we can do from a virtual perspective. Remote patient monitoring, text-based communication, virtual visits, even around specific encounters such as those. So really catering to that rhythm of their lives and making sure that we're able to integrate virtual into the fabric of care transformation. That's really the approach that I think we need to be taking.
And Rasu, was Atrium mildly surprised by that 10% number or shocked by that 10% number? Where were you sitting when you saw these numbers coming through?
Well, it did surprise us, but it surprised us in a good way because we were ready for it, right? So it wasn't, again, just something that we were able to stand up in the last year and a half. Now, clearly, we ramped up our virtual care offerings, much like every other health system across the country had to do. But I would think that this would be true for my colleagues here in this panel. But we had a number of years of runway where we'd been preparing for something like this, a surge that was going to hit us, the capabilities as well as the infrastructural components of what we've been pulling together. So surprised in a good way.
Fascinating. David, comments here about, what have you learned about analytics from consumer preferences? And then if you'd like to comment on, surprise, shock about what Rasu is seeing, maybe which might be different than what Geisinger and Central Pennsylvania might be seeing.
Yeah, absolutely. So I'd say, in terms of the, really seeing the access that I feel comfortable going forward is certainly behavioral health. We've seen, so, when first initial, we're reacting to COVID, we had this huge spike like everybody. And then in the summer, it kind of fell off a bit. I mean, it's still way more than it was before COVID, but then, and then another surge in the fall when we had kind of that second COVID surge. But the thing that kind of stayed consistent, a lot of our health specialties dropped in the summer, but behavioral health really stayed consistent. And I think because, we really found that the number of visits actually increased even when we closed our clinics, because our no-show rates were so much lower on the virtual visits than they were for the in-person. And so, I think behavioral health, as long as the payer rules, stay in force, I think that's gonna, go into the future. I'd say if I was looking for like say a unpleasant surprise, I would say for me personally, I don't know if everybody else, but cardio I've seen like really drop off, and we were doing a lot on that with phone even, and we'd really been pushing to try to do video wherever possible, but we really had a hard time getting into that. And I think part of the reason is the doctors really wanting to have those heart lung sounds, and so I'm hopeful though that as the vendors really keep developing these consumer facing tools, and if it becomes a little more ubiquitous for people to have a digital stethoscope in their home, that'll make some of those visits a little more palatable for our providers and patients.
Mm-hmm. And so, Rasu, any quick comments on behavioral and cardio? Maybe are you seeing any different data from Atrium's side?
No, from a behavioral health perspective, that's definitely an area where we've seen massive surge in virtual behavioral health demand, even amidst the pandemic, and perhaps because of it. And this is a virtual care arena that has really proven just as effective as in person since the 2000s. So this is not something new, but also at the same time, this is where it's really massively picked up. Before COVID-19, telehealth adoption in psychiatry was 80%. And that jumped to 96% in 2020 following the beginning of the pandemic. And 100% of those in psychiatry reported a willingness to use telehealth in 2020 post-COVID-19. So really, we're seeing a massive embrace in an area that was already looking at tele and digital as a means to really extend some of, I think, the challenges that really still bog us down in behavioral health, namely the stigma that's associated with mental health and behavioral health, and then at the access issues that have always been a big issue for us, especially in the United States.
Fantastic. So Judd, now you've heard both Rasu and David talk about this. So one, if you can start with what is your data showing you guys with respect to consumer preferences, and where these consumer preferences line up with what's good for them in general. And then any comments you want to make on maybe what Rasu and David are seeing that would be different or aligned with what you're seeing would be terrific.
So I'm going to take a different approach, because I almost have a heart attack every time he talks about tele behavioral health or tele this or tele that. It's tele whenever the hell the patient wants it, right? And doctors and providers just need to grow up and place patients first. That's the problem. If you're going to a cardiologist because you have chronic stable coronary disease and it's a routine evaluation for the meds, there's like no patient ever that had a new murmur that was asymptomatic walking into an office visit. Lose the damn stethoscope, grow up, take care of the patient. Osler said over 100 years ago, 95% of this is in the history. And let me tell you, when that patient calls to cancel, they say, are you having any symptoms? No, fine. Okay, we'll see you in 3 months. You certainly can see many patients by video without the toys we're used to. We don't need digital toys. In many ways, I think if we didn't have the digital toys and we forced people to take care of people, they would really figure out who they can take care of really well, and they would do great. So I am afraid as an industry, we spend too much time saying we could do this symptom, we could do this specialty. And I don't like to look at it that way. I really like to look at it as it's provider to provider. An example might be a neurostroke network or an EICU, or patient to provider, which may be on demand, or any specialty known to mankind. But what we have seen is we stink at predicting which patients will want to use it. And the stories I often tell are three, and David nods his head, he's heard them. Rasu's probably heard them already. Maybe even Shahid, you have.
I'm not going to admit it.
Okay, don't admit it. So and don't admit the first one, certainly. So urology, one of our major use cases was post-vasectomy care, right? Now, who would say a guy wants to flip an iPad over and show that part on video, right? People say, well, that's pornography. But you're seeing it in person if you're not seeing it on video. And the poor dude has to take a bumpy ride over Philadelphia potholes to get to the office to be seen in person. So it turns out wouldn't have been on my top 100 list, but ended up being really high where we grew it out. Bad news. Everybody's like, oh, I have to sit and hold their hand and give them bad news. And my analogy is always, have you ever been in like a trivial car accident? Everybody listening has, right? You're shaken up for hours and nothing happened to you. Now, imagine being told you're a Geisinger, you got to drive 100 miles to go home, right? And you just told you have cancer and there's nobody with you and you need to drive home. Or would you rather be in your living room with all of your family to hear either, hey, there's nothing wrong with you, let's have a drink and move on, or there is something wrong with you, and you could be shaken up at home without the risk of a car accident and going somewhere. So we've learned some people will choose one option and some people will choose another. And I would urge all of us not to get caught in the specialties, but get caught in the patient desires. And then it's not a fail to say, oh, you might be in heart failure. I really need you to come in tomorrow. I thought we tried on video. It didn't work. Because when you come to the ER where I work, you get a consult sometimes. You get a CAT scan. You get a test. Radiology, clinical correlation advised, recommend MRI. There's no other specialty or practice or healthcare delivery modality where we're expected to be 100% diagnostically accurate in 10 minutes with no help. We need to lose that. We just need to get to the right next step for the right patient in the manner they want.
No, I love that. And in fact, at HealthIMPACT, we pride ourselves on the no BS, and that's why we love having Judd on. That's about as clearly no BS as we can get. And so the extension of the question that we have a little bit more luxury if the pandemic really, stays down over the next 6 to 9 months. The luxury we have is now taking a look at the data, seeing what consumer preferences, and maybe I like to say, not consumer preferences, but consumer desires, which of course is stronger. Now, where do the consumer preferences and desires line up with better health outcomes? And I think that's what you kind of were alluding to, Judd. If it's good for health outcomes, take the desire and do it remote. But that's, I think, the trouble, right? We don't really know whether anything is better for outcomes. Or am I mistaken there, Jurasu? Do you think we have enough data to start telling us where the tele numbers are showing better outcomes or not?
I think we do. And it's not where it needs to be, but one of the things that we pride ourselves in here at Atrium Health, and you know the story, we talked about this the last time, but for those who don't, we've come together with Wake Forest Baptist Health and the Wake Forest School of Medicine here at Atrium Health. And together, we're a better learning health system than we've ever been in the past. And the learning health system construct, I think, is a really important one, right? As we're implementing specific interventions like what we're talking about here around virtual care and telehealth, how do we leverage data and analytics and evidence to really drive the specifics of the decisions as we're moving forward? So I think we do have hard evidence. I'll give you a specific example. Prenatal care, right? We have a maternal care crisis in the United States. 49% of the counties lack a single OBGYN. 55% of the counties lack a single CNM, certified nurse midwife. And we have extremely high maternal death rates compared to other developed nations. So the problem is especially acute in minority populations. And here in North Carolina, we rank 11th highest for infant mortality. And so when we think about the number of digital health startups and solutions that are really focusing in on this area, I think the needle is moving. Here at Atrium, we're using baby scripts. It's a notable solution that I think is really moving the needle in terms of the specifics of the outcomes that we're seeing on the other side. The solution really connects the patient and the provider to more seamless education, remote patient monitoring, integration with the EMR to enhance access to and compliance with specific care protocols, and really provides more of a warm envelope around the expecting mom and her journey throughout prenatal care, which we're not able to get to that level of care in the pre baby scripts era here at Atrium Health. So I do think that the numbers are telling, and the evidence is definitely out there.
Got it. David, do you agree that we've got the evidence being generated in reasonable ways to be able to make decisions off of, or where do we lack the evidence that we need to gather?
Yeah, So, I mean, the thing I'm excited about and we're working on at Geisinger is, we now have a full year of data, and to be able to look at, I think there've been a lot of studies comparing, a telehealth visit to an in-person visit, and, are they equivalent? And it's like, they've done that to death. It's like, yes, they in almost every case they are. I know. I see John's reaction. I know, exactly. And I agree. It's not really the question. It's like, but I do think we can look at the entire episode of care and see, is there some sort of optimal, mix of where are we able to more efficiently guide the patient through the system by perhaps getting them to a specialist faster by triaging better and things like that with telemedicine? Or are there instances where it does end up being duplicative, that you do a telemedicine visit and it's like, you got to come in anyway, and I think now we'll be able to look at an entire episode of care, say for cancer, or we're starting on behavioral health and looking to see, okay, that's great, we've got better no-show rates. That's more efficient for the health system to start with, but does that also translate into lower ED usage or fewer acute type incidents because we're able to keep them on schedule better with telemedicine because of better access? So those are the things. We're doing a big study right now to look at that. We don't have the data yet, but we're getting close.
Yeah, I love that. In fact, tying into that evidence makes a ton of sense. And, as we're going to open the questions up in about 5 or so minutes. So for our audience members, if you've got questions, please do put them in the chat. And if you want to come on and be on the same panel with the rest of the video, we can certainly invite you there as well. So Judd, if you were looking at, you've already said people need to grow up and get to understand that this is now part of, quote, standard of care. Obviously we have to use those terms very carefully, but if you were going to be very specific about advice about where people should grow up, what would you be telling them to do in terms of the next 3 months versus the next 6 months versus forward? Hopefully we're getting through the pandemic side, but what would you specifically tell them to change to grow up?
So I think the simplest thing is pretend you have no option. Pretend there's nothing else.
Other than telehealth.
You're in the wilderness. When you're on the telehealth call, you're in the wilderness. What will you do to take care of this patient's problem? And challenge yourself to come up with things. We have, when I give lectures, we have a CME program for physical exams. We show how we examine an abdomen. One of my favorite stories is I got a phone call after we were doing this in the pandemic for a while from a good general medicine doc with a huge practice that said, Judd, I feel horrible. These people are calling me and, I see a lot of people with abdominal pain and I can't examine them. So I'm making them come in and they're wasting money. And I said, well, what are you doing on your abdominal exam? And he's like, well, what do you mean? I said, I'm going to tell you what. I said, I'm going to ask you 2 things, and then I want you to call me back in a couple minutes. I want you to watch our 10-minute abdominal exam video, okay? And then I want you to just pretend you have no option. There is no hospital for 500 miles. You'd have to airlift people. Which of these people are sick enough to go there? And which of these people do you know have nothing? And then I talked about a couple of the techniques we use. One of the things we do is we make people jump up and down. You know what? When you're seeing a doctor and you say jump a couple times, patients think this is moronic and they're laughing hysterically. You don't need to go to the OR for something in your abdomen if you're cracking up while you're jumping. If you jump and it hurts you, we may need to bring you in person. And we have tricks that we've invented that are like that. And I think the beauty is we started out with a team of 15 people that challenged ourselves how to do it, exchanged it by an email listserv. You need to splint somebody, or you think they may have a broken wrist at 2 a.m. They don't need to, we know what you need to look for to see if they need something done now, an urgent reduction. Otherwise, they need to be splinted. Well, what's in your house you could splint somebody with? Is it a shoebox that you cut up? Is it a ruler? What do you use? And when we start challenging people, it turns out we are in our on-demand program, our referral rate to the ER is 5%, and 2/3 of those people get admitted or a procedure. So we've learned to be really good about what we could do at home. The problem with, the grow up is people weren't trained, right? If you're an old senior doc, you don't know what this stuff is. If you're mid-career, you've got clinical judgment, but you don't know how to apply it on telemedicine, which was the case with the doc I was talking about. And if you're just coming out of school, telemedicine is really scary because you don't have any clinical judgment and you haven't even learned to take care of people in person. So we have a whole spectrum of physicians from beginning to end that need to learn more and develop the confidence. So I think a lot of it is training them how to take care of people over telemedicine.
And Judd, if you were to be super opinionated, which I know you're never going to be, but let's pretend you can be super opinionated and say, is there a place where telehealth, virtual health is just not a good fit? Or you're just like, hey, just start there and make it not, prove that it's not useful rather than know that you're guessing.
So I don't know the answer to that, but we've taken the opposite approach. And we've said, when you come in our on-demand platform, if you're 80 with chest pain, it doesn't have a pop-up that says you're 80 with chest pain, don't do that. And one of my colleagues, Dr. Kleinman, saw literally an 82-year-old woman with nausea and vomiting and said, you might be having a heart attack. You should call an ambulance and go to the ER. And there's more of a backstory to it. But that woman was in the cath lab in 46 minutes from the telemedicine call from her house. So I don't want to treat chest pain, but he literally saved a woman's life. She was having an ST segment elevation MI at night. So we've taken the approach, we'll see everything, because I call it the activation time. The amount of time that someone will take before they activate an ambulance is considerably longer than the amount of time they'll take before they activate telemedicine. So if I could get them to the right spot of care 2 hours earlier on something I can't treat, wow, that's a huge help. So it's a very complicated question that you ask, but we've taken the do your best you can, get the right actionable information, and get them to the right spot as soon as you can.
Great. Yeah, so we've got a question in from the audience, and I'll present that first. And then I'd like for us to think about this extending to what Jed was talking about and saying, Rasu, if you are not going to go tell all your colleagues to grow up, neither are you, David. But just for this particular conversation,
neither am I.
And of course, but if you were going to, what would that look like? And could a telemed first model, almost like you're teaching all of medical professionals to be 911 operators, like they don't get the benefit of saying, I'll help you after everybody arrives. No. While help is arriving, you help people out, right? So there's a model for first responders in doing this, and maybe that's what we're teaching. But let's take Nick's question, and then we'll get to this other part. So Nick was asking, what specific methods have you found to establish trust with telehealth patient population to let them know you're not just a person on a screen and truly interested in the patient's needs? And that might help us kind of like segment these folks who maybe can be helped via telemedicine versus not. Rasu, you can take that first, and then David and Jed can jump in.
Yeah, that's Nick's asking a $1 million question here, because it is about trust. It is about the relationship. Lest we forget, this is a human relationship that we're talking about, right? And one of the dangers of the that pendulum that's swinging back and forth, and as we're swinging to one end of embracing virtual for anything and everything, that one of the dangers is that we lose sight of the fact that this is a human relationship that we're talking about, and the trust element is really important. So I think trust begins first and foremost with the relationship that you want to establish, or you need to establish, between the physician or the care team and the patient and their circle of trust around it. And so that's important. And so whether the first point of contact is an AI-powered chatbot, or it's a telephonic virtual video visit, or telephonic visit or a virtual video visit, I think it's really important to make sure that you do that handshake, you do that touch point, you add more of the humanistic elements to those touch points, and make sure that you're able to really start building those bridges between the clinician as well as the patient at the other end. I think the other element here is follow-ups. I think that's really critical as well. So whether it's for any of the synchronous or asynchronous types of opportunities, follow-ups on a very regular and consistent basis is really important. And as we're thinking even about care transformation, as I was talking about earlier, where we're going from more episodic care venues to more of the pervasive, always on 24/7 type of care transformation opportunities, that level of follow-up, that level of always knowing with the comfort and the trust that you have your provider or your health system almost as a digital guardian angel, right, by your side. I think that's really important. So the trust element is a wonderful question there from Nick, and I think it's one that we should not forget as we're in the hurly-burly frenzy of adopting anything and everything virtual.
That's right. And David, as you think about that same question, are there specific techniques that you may have used or are teaching your physicians, such as, do you start with small talk, or don't ever start with small talk because of XYZ? How do we get folks to get comfortable? Obviously, at least the four of us on this call have done so many videos now, but we got a good sense of how to start a video, how to be in the middle of one, how to joke around, how to not joke around. What do you teach, David, in terms of training? I shouldn't say teaching, but training to help with those techniques to build and engender trust?
Yeah. So we do, as part of our training for the providers, to learn how to use the software and all that, is we talk about website manner, and we talk about some of those exact things that it's easy to lose track and be writing in your notes and forget that there's a camera here and that you're not looking at the patient. Of course, that happens to me when I'm in person as well. So we don't want to recreate that problem on our web-based as well, or video-based as well. And so we do that, but I think there is a lot of room, and I'm excited for like a lot of the work Judd's doing, and I think some of the more kind of standardized ways of training. I think there's a lot to be done there. Another thing I've noticed in our, we do Press Ganey surveys for our telemedicine visits, and kind of toward next question, I think I found a lot of respondents saying, "Man, this is great. I'm so glad. It was easier than I thought it was going to be. I'm so glad you were able to do this during the emergency. Can't wait to get back and see my doc in person." And I think there's a little bit of a perception that this was an emergency measure, a suboptimal visit, but just to get by. And so we're actually working kind of with our marketing team to get the word out, that we'll only offer telemedicine when it's clinically appropriate, and that it's something that is going to continue on, beyond just the pandemic. And then I think, kind of to your earlier question, the other big thing that I find that I is sometimes the most frustrating to me to kind of try to stomp out is that there's a preconceived notion that older folks aren't going to really be interested or want to do telemedicine. It's really, this is for the younger folks. They're going to take to it, and I don't find it. I don't find it in our surveys. I don't find it. We have so many older folks that love it because it makes their lives so much easier. We had a patient who had a brain tumor, something I would have never even thought of. And he said, every time I had to go on campus, go in the elevator, I got sick because of my brain tumor. And so being able to just do this from my home was just a godsend, made my life so much better. And so I think there are all these examples. And so, we found in that Press Ganey that our older folks liked it to a greater degree than older folks throughout the rest of the country. And I think part of that is because we really held the line on not requiring patients to go through a portal and go through all these myriad steps to get into a video visit. We send them a link, they click the link, they're in the visit. And I think, if we're smart about how we set up the process, the older folks love it just as much as the younger folks. And so I think, that's part of the thing. Some of these specialties even assume it's like, well, my patients are older, they're not a good fit. And it's just, I don't see that in the data at all. I don't think that's really true.
I think that makes a ton of sense in this case. So Vishnu has a question, and I'll pose that in a second. It's a question similar to what you raised a little while ago, Rasu, around follow-ups. But with Judd, can you talk a little bit about how you're training for this website manner, or how do you engender trust? Or is it a useful question, right? I mean, what does trust have anything to do with the fact that you're going to get somebody on a video and you're going to help them or you're not going to help them? Does trust matter? And I think Rasu definitely agrees that it does. And I think David said so as well. But we'd love to hear the opposite view if you have one.
Well, so I don't have the opposite view. We actually have I might have a more blunt view, but not the opposite view. We have a paper that Kristen Rising just published online where the biggest correlate about whether people do telehealth or not is not actually about access and digital readiness, but it's actually about trust, which relates to the area deprivation index and just came online yesterday. But we've spent a lot of time looking at trust, and I'm going to break it down into 3 simple buckets the way we view it. One is helping them get access, whether it be scheduling appointment or digital readiness and how that works. And Kristen, I just mentioned her name, God bless her. She's so into this. She's working with the vulnerable communities. She has a Center for Connected Care, research dollars to look at this, just got a PCORI grant to figure out how to do it better, to host a conference. You know, a lot of movement in this area. That's pre-call. Then there's during the call. And so it's really, and it's hard to do during the call, but immediately thereafter is good. We have had an enormous effort. And one of the dirty little secrets about telemedicine is it's not perfect. It fails. And it's more than 1 in 100 times. In fact, at many shops, it's more than 1 in 5 times the patient can't get on the video, whether it be due to a hospital issue or vendor issue or patient issue. We have been so diligent. We get reports, live reports. We don't have an operations center, but twice a day a report is sent to me on what our hiccup rate is. And so we know as soon as it starts trending up, oh, is it Google Chrome released a new browser? Did Apple release a new operating system that the audio doesn't work on? We find these things on day 1 or 2 now and start dialing down. And we keep our hiccup rate today is 7%, which is unbelievably good. But nobody out in the world knows that 7% of these calls fail, right? And a fail might be the patient can't even log on. So it might not be something we could fix. That's like a really good number, but it's far from perfect. So dialing that down, that number is sort of the intra-call trust. Then we survey the providers at the end of every call, which is when we start seeing hiccups, we now know, is it an audio video issue? Is it intermittent? So we could start doing a deeper dive on what it is and pull their technical data to see what the browsers are. And then we have, we do get Press Ganey, but we use our own homegrown survey that allows us to not just get patient experience, do I love it, Net Promoter Score stuff, but lets us get actionable items that we could fix. And now we're working on making that dynamic so it'll be variable by specialty and maybe by age group of the patient and going after that. So pre-call trust, intra-call ability to make sure the call happens, post-call follow-up, and then we are really diligent, particularly in the on-demand platform, like just go above and beyond. Like you tell the patient to call for a sono, call for the sono, connect them on the phone, give them that extra step that nobody else does, and they come back. And, you know, our providers have been great at doing that.
Yeah, I think delighting the customer is actually a nice thing to do, even in healthcare, delight them. So one quick note for the audience is, you guys probably heard very recently that iOS 14 on all your iPhones and iPads, et cetera, has a new privacy mode. This is one thing that I've seen on a lot of telemedicine calls recently is privacy mode has been turned on, and now it forces you to say yes or no, to say, are you okay talking to this app, right? Which is really talking to Judd or somebody on the other end. And you actually have to go to a place on your Mac OS or your iOS devices to go say yes to that thing. So that might be something you guys want to add to your thing. It's just recently, it's just 2 weeks old. So we've been caught up with that in a number of our situations, unfortunately, that causes that 7% hiccup rate to go really, really high. Yes. And the patient thinks it's our fault. And we're like, no, your device is doing a good thing, which is giving you more privacy and making you consent to this thing that you didn't have to do before. So just a side note there. We've got about 4 or 5 minutes, and I'd love to talk about Vishnu's question. He asked, how do you do the continuous patient engagement post the telemedicine consultation episode? Judge, you just mentioned delight the customer, do the follow-up. Rasu, how are you guys looking at this post-engagement consultation as far as follow-ups are concerned in specifically?
So 2 things in particular, really great question there from Vishnu. You know, when you look at some of the successes that we've had, even in the last year and a half of us really pushing the envelope around tele, you know, one example that comes to mind is our Atrium Health Hospital at Home program, right? Amazing work there in terms of virtual care that we're able to provide to our patients, COVID-19 patients, enabling patients to heal where they're most comfortable and it's safest for them in their communities, in their homes. But how we're extending this, back to Vishnu's question, is leveraging the power of remote patient monitoring, connecting to the virtual care team, and connecting it back into in-home care as required. But that concept of the digital, warm blanket, right? The guardian angel concept that I was talking about earlier is one that we're really moving ahead with. So specifically, when you're looking at patients with chronic illnesses that need to be monitored over time, you might have an episodic visit that could be virtual, but how do we make sure that we're able to then monitor them over time, leveraging the power of remote patient monitoring? The one other component that I'll just quickly throw out there, because I know we're going to run out of time, but I didn't want for us to not talk about this today, is virtual, as we all know, but I want to call it out, is not a silver bullet for everything, right? And one of the key areas that we really need to remember is the gap between the haves and the have-nots. When we talk about specific populations that don't have access to internet, that don't have access to digital, that don't have a smartphone, and we need to be really mindful of how does what we're continuing to push ahead with, how do we meet them where they choose to meet us, where they're forced to meet us. So we really talk about digital health as a digital in-health strategy, right? How do we leverage the power of digital in our pursuit of healthcare for these populations, as well as for others that do have access to all of these capabilities, including the remote patient monitoring components, back to Vishnu's question.
Yeah, that's great advice. And David, you mentioned a little while ago that the cardio side was dropping faster than you would have thought that it would have. It would seem like the remote patient monitoring based follow-ups would be a natural there. Why do you feel that the cardio side isn't picking up there? Is it people have to grow up, or is it more substantial than that?
Yeah, I think it's pieces of that, and then it's also the just the dynamics of who's going to pay for that follow-up equipment. Is it going to be which payers are going to allow it, which ones and so it ends up being we do have, because we are a fully integrated system, we do have some really nice, like Geisinger at Home, where we actually send nurses and CHAWs into the patient's homes, and we use telemedicine to bring in docs and specialists when needed. But it's just, I think it's a combination of those kinds of logistic things, and then also maybe a little bit of a cultural thing in that specialty. The only other thing I'll touch on is I think for those follow-ups, and I do worry a lot about, are we going to exacerbate the problems of inequities in care, and so one of the things we try to do is, for patients who don't have access to broadband, we get them to the nearest clinic, so a clinic near their home, so they don't have to necessarily drive 2 hours through the mountains of Pennsylvania to get to our tertiary care center, and then they can do telemedicine from that clinic. It's difficult logistically, but yeah, we think it's important to try to really reach everybody and get them access to some of these great tools that everybody's put out in these last few years.
And that's great advice. Is telehealth doesn't necessarily have to mean from home. It could be wherever the closest telehealth capability is for those who don't have it. And the last 30 seconds, Judd, any very concrete advice about how to do follow-ups well to keep that trust in that post-visit going?
I think we just need healthcare providers that are devoted to taking care of the patient. I think in David's system, where you're a fully integrated system, and other fully integrated systems that are heavily value-based care, that's a little easier than when it's fee-for-service systems. But I think that's what we need. It's not a telemedicine problem if the care coordination is bad. It's a provider problem. And we never said it's a fifth floor problem if there's a bad doctor on the fifth floor. It's a doctor problem. It's the same thing in telemedicine. So we need capable providers that care about patients no matter where and how they're practicing. And that's what we should look forward to.
Perfect. All right. That was great. And Rasu had a hard stop, so he had to jump off. It wasn't because of anything Judd or David said, or maybe it was me, but no, he had a good hard stop. Let's go ahead. I wanted to thank Rasu, David, and Judd. We're going to move to our next panel now. Please join us on that next side, and we'll see you there in about 10 seconds. Thanks, guys. Bye.
Bye-bye.